or he may have due to spontaneous improvements occur during the process of the disease. Therefore, it's important to evaluate and to assess the patients with a stroke. And according to Boat approach, in this approach, you need to consider the assessment of postural tonus and motor patterns. You need to test sensations. Therefore, sensory testing is one component suggested when applying this approach for treating patients with a stroke. Testing tonus and postural reactions to being moved, and tests for the quality of movement patterns, and finally test for balance and protective reaction. And if you focus about what I said about the basics of the Boat approach, you can perceive these components are necessary and are closely related with those provided for the neurophysiological basis of the action. For postural tonus, you need to evaluate the postural patterns and spasticity. When assessing a patient with a stroke, they may suffer from spasticity or flaccidity, or some people with a stroke may have mixed postural tonus of spasticity and flaccidity. For example, such a patient may suffer from flaccidity of the upper extremity, but the spasticity of the lower limbs. All right, and finally, movements, patterns of the patients with a stroke should be assessed. Is it in the form of synergies and mass patterns? Usually, all the patients with a stroke have synergistic patterns, inflection and extension for the upper limb and the lower limb. Yesterday I described the grading provided by the Boat for her approach. If the patient suffers from spasticity, therefore you need to assess the grades of the spasticity, being severe, moderate, or mild. Sensory testing is another component suggested for the approach of MDT and Boat approach. Sense of position, appreciation of movements, and localization of pressure and light touch are used. And test for stereognosis is another component of sensory testing. Do you know how we can test for the sense of position?
The patient to close his eyes and
Where are you? Yeah.
the patient to close his eyes, and we ask him elevate your leg or something like that, and he told us about.
He must report the position of the wrist. For example, after describing the procedure for the patient, and first performed on the intact side, when he understood the procedure, you close the eye, you move the, for example, shoulder into abduction, you stop it and ask him to report the position of the shoulder. Or you keep the elbow in extension, you ask him to report the position of the affected elbow, or report it or show it on the intact side. That's right. What's the appreciation of movement? All these testings are performed for the upper limb as well as for the lower limb. How appreciation of the movement is performed? Again, you describe the procedure for the patients. All right, first you perform the procedure on the intact side. After understanding of the procedure, you close the eye, you ask the patient to close the eye, or you may use a cloth to blindfold the patients. Therefore, you move the, for example, shoulder in abduction, abduction, as you ask him to report what movement you are doing with the affected upper limb. Or abduction of the lower limb is performed, you ask him or you ask her to report the movements performed with the affected lower limb. Alright, therefore you record the result. For the localization of pressure and light touch, the pressure is the same as the procedure I described for the sense, position sense and appreciation of movement. You describe the procedure, you show the procedure on the intact side. When understanding the procedure, you ask the patient to close the eyes or blindfolded the clothes, and then you pressure using your thumb. You can use to apply pressure on various locations on the limb, upper and lower limb, and then you ask them to report where you press the skin and muscles. All right. The localization of the pressure must be reported by the patients on the intact side, or they may report where it's pressure. All right. For light touch, you use your finger pads, or cotton may be used to lightly touch the skin, various parts of the upper limb and lower limb. All right, randomly you can apply the pad of the thumb, pad of the finger or cotton to lightly touch the various locations on the upper limb and lower limb. Usually the pressure is better perceived when compared to light touch, and generally the sensation of the lower limb is better than those of the upper limb. Why? What do you think about why the sensation is better for the lower limb when compared to the upper limb in patients with a stroke? And usually the sensation of the proximal segment are better than the distals. And usually the sensation of the fingertips are lost most of the time in most of the patients with a stroke. Why lower limb has better sensation when compared to the upper limb?
Because the amount of the receptors in this area?
No?
Because we use the lower limb only for walking.
For standing and walking.
Yeah.
In early period after the stroke, the people with the stroke experience walking, standing and walking. Therefore, due to the standing and walking, they are under pressure and they are under stimulation. Therefore, the sensation is usually better when compared to the upper. But what is stenosis testing? What test is this examiner is doing in this figure?
Check this.
And in this figure. What's testing?
That's light.
Light touch.
And pressure.
Excellent. Good job. All right. What is stenosis? Stenosis. How is it tested? You see that?
Describe, give subject to the patient, and he will describe about it, about the size and the shape of the subject.
Again, please. Louder to hear you.
Give subject to the patient and ask the patient to
You
describe
place,
about this.
you place an object or a familiar object of yours, such as coin, pen cap,
For
something
example,
like
I give
that.
the
All right.
speed to the.
Why, after describing the procedure to the patient, you ask the patient to close the eyes or is blindfolded. Therefore, you place a familiar object, such as coin, for example. All right. The patient must manipulate the object, all right, to report what is touching, all right, what the object is that's placed in the hand of the patient. All right. In normal person, they usually report the correct object, correct, they report the correct answer. And people with this stroke may have asteroidnosis, reporting wrong answer. If wrong, as a result, what's the problem with such a patient? All right, close your eyes. Open your hand. Open your hand. Close your eyes. Close your eyes. All right? What? Something. We ask him while the eyes are closed to touch the, for example, pen cap and to report what it is that I place it in the hand of the patients. Size, shape, quality, texture is evaluated by the patient, that finally he reports what it is. Normally he has no problem, or I can recognize, can identify the object. But people with a stroke, again, most of them cannot recognize the object with the test of stenosis. Therefore, they suffer from stenosis. A patient with a stroke, if cannot recognize, if cannot identify the shape, what the problem is with the patient. Ali Omer, what the problem he has if the test is negative?
The sensory signals or receptors.
Prefer receptors?
Yeah,
There are problems with this.
And receptors or in the signals of the sensory signals of the nerves.
No. Any other idea?
Proprioceptive sense?
No. Sternose is testing what?
Proprioception.
Not proprioception, it's touching. It's trying to perceive, to recognize, to identify the object with touch sensation. Therefore, the processing of the signal is evaluated in the parietal lobe of the brain. If he is reporting the normal correct answer, therefore the processing is performed normally in the parietal lobe of the brain. And if the patient with a stroke is reporting wrong answer, therefore there is a problem with sensory processing in the parietal lobe of the brain. Therefore, it's a test of somatosensory processing in the brain, the parietal lobe specific. Alright. Tonus, testing of tonus and postural reactions to being moved. Please tell me what this test is evaluating. What about this assessment of the when testing postural tonus, why the limb is being moved? For example, the left side is affected, all right? I move the affected limb, upper limb, in flexion and in extension. All right. In this way, I assess the postural tonus of the flexors and how this patient adapts with the patients, how the patients adapt with the movements being with the affected upper limb. in this way, I assess the postural tonus of the elbow flexors, and the most important thing is that I'm assessing what with this maneuver, moving the arm, for example, in flexion and abduction. In normal condition, he immediately, shortly adapts with the movement. I feel the limb is light because he's shortly after being moved, adapts with the movement and helps with the movement like this one. But in people with a stroke, when extending, there is a resistance. Don't let me to open it. Don't let me to extend
Not leave them.
Yeah. Depending on the severity of the spasticity of the elbow flexor, I feel resistance. All right, when extending the elbow. But when flexing, there is help and he assists reflexively and voluntarily to the movement, such that I can have sharp flexion of the elbow because I'm moving the elbow in direction of the flexors that are spastic in this patient with a stroke. Therefore, in flexion, I feel assistance with the movement due to the spasticity of the flexor, and I feel resistance when moving the elbow in directional extension. This indicates that the postural reflexive mechanism is abnormal. The normal reaction to the movement being performed with the affected arm or affected lower extremity indicates the postural reflex mechanism being normal. If he follow the movement being performed with his limb. But if there is assistance with flexion and resistance with extension, and he cannot adapt with this movement, therefore the postural reflex mechanism is abnormal, is not working normally. All right, in this way, I assess the postural tonus, spasticity, and also I assess the postural reflex mechanism. Besides this, to test the postural reflex mechanism being normal or abnormal, I can use the placing maneuver. I move the affected upper extremity into abduction like this, and suddenly, without telling something without warning to the patients, I drop the upper limb. In normal condition, the normal person can control the upper limb to bring it to the wrong side of the body. But in patients with hemiplegia, post-stroke, when dropping the arm from abduction, they cannot control it. And they experience such a response when dropping the upper arm. Therefore, with placing maneuver, again, I tested the postural reflex mechanism. If it is working, therefore, he can control the upper limb when moving it towards the abduction to bring it to the wrong side of the body. But it is negative, there is problem with postural reflex mechanism when the patient cannot control the upper limb when dropping into abduction. All right? All right, you are treating a patient, you tested the placing maneuver. When you drop the upper limb from the abduction 90 degree, he controlled the upper limb and brought the upper limb into abduction with control and placed it alongside the trunk. What the outcome is and what do you conclude when the patient can control the dropping of the upper limb on the affected side? You dropped it, but the patient controlled it after, for example, 20 sessions of treatment. after sessions of physiotherapy provided by you, now you are using the placing maneuver to see whether you can control the upper knee when dropping from the abduction 90 degree or not. But you found that he's able to control it. He was able to control it. This indicates that what mechanism is intact and is working normally? What mechanism is working? Using the placing maneuver, we drop the affected upper limb from abduction 90 degree, and the patient controlled it towards the abduction and placed it smoothly alongside the trunk. Your treatment was effective or was not effective? In fact, you tested the posture reflex mechanism. When moving the arm, alright, when I move the affected arm of the patient into flexion extension, I tested the postural tonus of the elbow flexors. Also, I assessed the postural reflex mechanism. Another test to test the postural reflex mechanism, whether it's normal or not, we can use placing maneuver. Come here, please. And drop your hand and don't control it, right? Let him drop. Is it normal?
No.
What I'm testing right now?
Postural
Reflex
reflex
mechanism.
mechanism.
Is it working or not? It's not working. There is problem with postural reflex mechanism and it is abnormal. Now he controls after 10 sessions. I drop it, but a little bit will drop, then he controls it and smoothly abduct the arm to place it alongside the trunk. Therefore, it's treated successfully and the postural reflex is acting normally or abnormally? Normally, because he controlled the upper limb when dropped. One component of the Bobat approach are tests for quality of movement patterns. If you read the book of the Bobat, you will find the movements suggested for testing quality of movement. She suggests 3 grades of tests for quality of movement patterns. The tests for grade 1 are the easiest ones, but those for grade 3 are the most difficult ones. But it's interesting that most people with a stroke even cannot do the grade 1 movement patterns. Therefore, usually we don't apply this test when evaluating the patients with a stroke, because most of the time, most of the patients are not able to voluntarily move this selected movements. They cannot isolate the movements to the desired movement they intend to perform. Therefore, most of the time, they perform the patterns synergistically into flexion and extension. Therefore, even they cannot perform the easiest grade 1 motor patterns suggested for quality of movement. But the last items when assessing the patients with stroke are tests for balance and protective or extension. or parachute reaction in different positions. As you see here, in supine position, what test is this trapeze is performing? Here, she pretends throwing the pillow towards the face of the patient.
Right?
All right, she pretends that she will throw the pillow towards the face of the patient. What test she is doing? Parachute reaction. Even in supine position, the intact arm is under the back to control the reaction of the intact upper limb, and is trying to train the parachute reaction on the affected side. Therefore, he pretends to throw the pillow towards the face of the patient. Normal reaction is protective extension of the affected upper limb. All right, again, in standing position, what test this therapist is doing?
Push-up? Push-up test?
No, I mean parachute.
Parachute reaction. He is trying to test the protective extension of the arm. For safety, he considers the wall to control the balance of the patient. Again, what test he is doing here in the sitting position over the edge of the bed? Here, writing reactions. The trapeze is testing writing reaction in this patient with a stroke. We can test the balance reaction in standing position, all right, with moving it suddenly to the right, left, forward, and backward. With the performances, we test the equilibrium, test the balance reactions of the patient with a stroke. All right, do you have any question? All right. Now we learn about the neurophysiological basis of the Boat approach. What constitutes the postural reflex mechanism, normal postural reflex mechanism? We reviewed the factors effective in producing normal movements, the items being abnormal postural reflex mechanisms such as associated reaction, asymmetrical TMR, PS or positive support reaction. And now we reviewed the assessment principles using the Bobat approach. Now we want to apply this technique for treatment. What are the techniques used for treating patients with a stroke based on and according to the NBT approach? Just for you remember that the aim is to improve the quality of movement on the affected side using the NDT approach. I again emphasize that the focus is on the affected side. This approach aims to help the patients with a stroke that the two sides of the body to roll together coordinately or harmoniously. Remember that the techniques described are only suggestions and ideas of what can be done with a patient with a stroke. In practice sessions, I will suggest some exercises based on this approach. But this point indicates that those exercises that I suggest are just suggestions. And you will need to get sufficient experience. First, assess the patients, and based on the assessment's finding, adjust your techniques to help the patient to recover. Therefore, the techniques I will present next month should not be considered as a session of exercise, succession of exercises or patterns that to be used for all patients with the order I will explain to you. The assessment finding determine what techniques to be used and from what position, supine, sitting, standing, or walking. Therefore, techniques should not be considered as a succession of exercises or patterns to be used in the order given and for all patients. Therefore, you need to adjust the techniques, even creating new exercises based on the findings obtained with the patients and the recovery stage of the patient. Therefore, the techniques selected and used for patients depend on the individual patient needs and their effects tested within the same treatment session on the patient's recovery. An important point for you to remember that the effects of techniques applied must be tested within the same treatment session. If it is not effective, then use another technique, even within the same treatment session. If your treatment is effective, the effects will show itself in changes in postural tonus, in motor patterns, in functional use. If your treatment is effective, I can extend the elbow, postural tonus normalized. I can use different motor patterns out of synergies. Now I can extend the wrist joint independent of the elbow and shoulder joints out of synergies. All right, now independently and selectively and voluntarily, I can extend and flex the wrist joint. I can extend the elbow joint. Now I can abduct the arm. I can flex the shoulder. In this way, you can evaluate your effectiveness of your treatment. Changes in postural tonus, producing voluntary selective patterns, movement patterns, and I can use the limbs in functional condition. For example, now I can reach out to a cup of coffee, bring it to the mouth, I can drink my coffee. Selectively. Remember that no one pattern and no one technique should be made responsible for an expected reaction. Collection of techniques you use to have an effective outcome in patients with a stroke. Therefore, the collection of techniques applied. In the other words, the interaction of the benefits of all techniques collectively can lead to the improvement of patients with hemiplegia or post-stroke. Therefore, no one technique should be made responsible for an expected reaction. But remember that if you observe no changes after treatment, or there is a change for the worse, therefore the attempted technique must be discontinued. I already said that. When you observe that the specific technique is not effective, therefore use another one. Don't continue with that technique that worsens the outcome. Try another technique. But experience is important. The technique or the pattern may not be unsuitable, but the problem is with me as a physiotherapist. I cannot apply the techniques correctly. Therefore, the way I use the techniques may produce the undesired response. Therefore, I need to read deeply the materials, the documents, to practice it with normal subjects, and then to apply the techniques in patients with hemiplegia. And experience is important. You need to apply the techniques correctly in patients with stroke, with hemiplegia, with spasticity, to have sufficient experience to apply the techniques correctly. Therefore, sometimes the way I use the techniques is not correct. Therefore, produce undesired response. Therefore, the experiment of the physiotherapist is important. Point that should be paid attention. Therefore, techniques are tools used by the physiotherapist and therefore are interchangeable. And the communication between the physiotherapist and patients are important. Therefore, everything depends on the constant feedback between patient and therapist. You need to communicate with the patients. You need to pay attention to the feedback provided by the patients and to consider it when you select the technique to apply in a specific particular patient. Therefore, reactions of the patients must be considered when assessing and when treating the patient with hemiplegia. And the constant feedback provided by the patients can guide the physiotherapist to apply to choose the effective technique for a specific particular patient. Therefore, the reactions of the patients are treated constantly by the patient's reactions and their response to the handling provided by the patients. In this way, a systematic treatment will be possible to obtain better results. But the techniques applied depend on the recovery stage. Bobat suggests the recovery stages as initial flaccid stage of spasticity, and stage of relative recovery. And depending on the recovery stage, the techniques applied would be different. First, initial flaccid stage. The flaccid stage is considered soon after the onset of the stroke, lasts from a few days to several weeks, and there is a complete and sudden change occurring in patients with a stroke, and patients are confused and disoriented. There is no interaction between the two sides, and they cannot move the body on the affected side. The patient with a stroke cannot turn over or over to the sound side, cannot sit unsupported, stand, or walk. In the flaccid stage, there is no midline orientation. They cannot keep the body in the midline position when in sitting position. Remember that at the initial flaccidity stage, there is no restriction of passive joint ROM on the affected side. All right. Initially, at the flaccidity stage, there is no contraction. There is no restriction of joint range of motion on the affected side. Therefore, the ROM is complete on the affected side for all joints on the affected side. But how is the position of the patients soon after a stroke? Usually, at the flaccid stage, the patient's position in the neck is like that. The neck is in lateral flexion towards the affected side. What does it mean?
If the right side is infected, so yes.
Side lateral flexion towards the affected side.
So the
It's
infected
like
the
that.
right side.
What does it mean? Yeah. What's the effect of such positioning of the neck? If it cannot be controlled, if you don't pay attention to this position. When you go to visit a patient with stroke at the flaccid stage, you will find that the neck is in lateral flexion, but towards the affected side. What does it mean? Assume affected side is left side, all right? When you go to visit a patient with a stroke, you find that the neck is in lateral flexion towards the affected side, like that. In fact, he is watching the sound side. Affected side is the left side. There is a lateral flexion towards the affected side. Is watching the sound side. If we don't pay attention to this, this will lead to the neglect or hemianesthesia, because there is a lateral flexion towards the affected side. Therefore, she is vulnerable to neglect and hemianesthesia of the affected side. Shoulder and arm are retracted, but the elbow at this stage is still extended. It's not like that. It's still extended, forearm is in pronation, leg is extended and laterally rotated, ankle is in plantar flexion and supination. The whole of the affected side, shoulder girdle and pelvic girdle, is rotated backwards or is retracted. Therefore, at the initial stage, there is lateral flexion towards the affected side. The elbow is still extended. Alright? And there is no restriction in the ROM of the joints. There is no midline orientation to keep the body in midline position in sitting position. Why there is no midline orientation? Why they cannot maintain and keep their body in midline like this one? They experience falling towards the affected side.
Because there is no balance. There is no balance.
There is no balance on the affected side. Other item? Because the body is divided to two sides, affected and unaffected. Therefore, sound side doesn't know what's happening on the affected side. There is no interaction between the two sides of the body. And there are different sensations on each side. One side is normal, sending normal sensation to the brain, and other affected side is sending abnormal signal to the brain. That's why they don't have midline orientation. All right, one more important point. At the flaccid stage, since there is no spasticity, therefore there is no associated reaction. Therefore, at flaccid stage, the ROM is complete, and also there is no spasticity and associated reaction. All right? Nursing is important during the flaccid stage, and the interaction between the nurses and physiotherapists are important to prevent complications in patients with a stroke. But one important point is that many problems are similar in all hemiplegic patients after stroke, but not all people with a stroke are affected to the same extent or in the same way. And problems are individual. All right, are different. Problems are individual in patients with a stroke. Sensory deficits of varying degrees may be observed in people with a stroke. Tonus quality is different when comparing the people with a stroke. The age of the patients are different. Some people may suffer from anxiety and insecurity. Some suffer from fusion and have mental and emotional problems. And some people have speech involvement, aphasia, and some do not have aphasia and communication problems. Therefore, each patient is unique and problems are individualized. Therefore, the treatment techniques must be individualized according to the assessment of each patient. Another important point, in such patients with a stroke must be active, to actively participate in their treatment, must not be passive. And you as a physiotherapist to perform all movements for the patients. Therefore, you must encourage the patients with a stroke to take an active part during treatment, because he has to relearn all his movements from the beginning, to take part actively during the process of treatment. You have to give sufficient time the patients actively perform their suggested movement patterns, movement patterns. Therefore, you need to communicate with the patient to give the patient sufficient time to perform their suggested movement patterns. And repetition is important. To learn the movement patterns, much repetition of the movements are required or necessary. They are necessary. Even it's said that in the literature, one movement should be at least repeated for 300 times. Some believes that for learning the movements, even for each movement, for example, flexion and extension, 2,000 times, the movement must be repeated. Therefore, much repetition of the movements are required to establish the engrams, neural engrams related, associated with that movement. Their problems in some area, the body is divided, semi-divided into two sides. The postural tones of the two sides is different, and the patient no longer knows how to move. That's why you have to give sufficient time to learn the movements, to perform the movements actively. What's the outcome of these problems? They don't shift the body, they are reluctant to carry the weight on the affected side, not to use the affected side for their function. Again, I emphasize that patients should not be moved hurriedly and nor should be passive. In the other word, they must be active to take part in the treatment of their problems. All of these problems, divided body, different postural tonus on each side, and not knowing how to move, cause fear of falling in the patient even for a long time. In the flaccid stage, we aim to obtain extension, external rotation, abduction and elevation of the arm, and to be able to flex all the joints of the lower extremity. Therefore, the aim in flaccid stage is to obtain extension, external rotation, abduction and elevation of the arm, that they are really important. Which one is difficult to obtain? Extension, external rotation, abduction, elevation. Abduction is very difficult. All right, abduction is one of the difficult movements to be obtained in this patient. And the elbow extension is also very difficult. And the flexion of all joints must be obtained. We aim to obtain flexion at all joints. But the dorsiflexion again and knee flexion are movements that are difficult to obtain. In flaccid stage, what we have to do? Proper positioning is important, and proper handling. How to move the patients with a stroke. in flaccid stage. In this way, we can control typical patterns observed in patients with SO. Therefore, it was one of the questions for the exam, final exam, that what we have to do in flaccid stage. The aim is to obtain proper positioning and handling. The proper positioning and handling are the most important nodes in the flaccid stage. Exactly, we ask about proper positioning and handling, proper handling. Why positioning is important? Why proper positioning is important? With proper positioning, we can control the tonus, to normalize it, to keep the skeletal alignment, to increase the stimulation to the affected side, and finally facilitate the normal movement patterns. After initial flaccidity stage, the people with this stroke enters the spasticity stage. Bower believes that even during the flaccid stage, there is some spasticity in some specific muscles. Therefore, there is a gradual development of spasticity occurring during the flaccid stage. Here, during the spastic stage, the process of spontaneous recovery is often arrested, and they reach to a plateau of recovery. And at this stage, most of the patients with hemiplegia post-stroke come for physiotherapy, come for receiving outpatient physiotherapy and rehabilitation. The spasticity usually develops slowly, as you know already, that arm flexors and the leg extensors will be spastic, will show spasticity at this spasticity stage. What muscles are spastic? What muscles are spastic in the upper?
Biceps.
Depressors of shoulder, girdle, and arm. There is depression of the shoulder girdle. Fixators and retractors of the scapula. All right, it's like that. Side flexors of the trunk on the affected side. Adductors and internal rotators of the arm are spastic. Flexors and pronators of the elbow and wrist. And flexors and adductors of the fingers, like that. This posture, all these postures show that these muscles are spastic, producing the typical flexion posturing of the upper. All right, retractors, depressors, adductor and internal rotators of the shoulder, flexors and pronators of the elbow and forearm, flexion of the wrist and flexion adductors of the fingers.
Why the flexor of the trunk is affected?
You know, all flexors in the trunk and upper limb typically involved in the spasticity stage. That's why side flexors, as as a group of flexors will be affected and show some shortening due to stiffening, especially from spasticity.
For whole trunk or just one
So
side?
just one side of the body. On the affected side, of course, it's not severe usually, unless if they use the assistive device for walking in later stage, for example, in recovery stage, they may show not spasticity actually. They show shortening, especially on the affected side. Therefore, it's easily, you can apply stretching to elongate the side flexors. One of the techniques we use in treating the patients with embolism is stretching and elongation of the side flexors of the trunk on the affected side. Therefore, these muscles are affected. Even when using dry needling, you need to know what muscles are spastic. We will show where the motor points of the spastic muscles are for applying dry needle exactly inserting the needle to the approximate motor points of the muscles. But the spastic muscles of leg are extensors of the hip, knee, and ankle with inversion or supination of the hip, like this one. This is the extension posturing of the limb when the extensors of the hip, knee, and ankle are spastic, along with invertors or supinators of the feet. As you see here, the extensors are affected. Therefore, in the upper limb, the flexors are spastic. In the lower limb, which muscle groups? Extensors are spastic. All right. During the spasticity stage, they suffer one of the major problems and challenges is spasticity of the upper limb and the lower limb. With spasticity, they cannot perform the antagonistic movements. For example, in the upper limb, the elbow extension, and in the lower limb, for example, knee flexion. In the lower limb, when you ask the patient to perform, for example, knee flexion or the ankle dorsiflexion, they show the synergy in the direction of flexion. They first flex the hip joint. In this way, they activate the flexion synergy and use the flexion abduction of the hip with flexion of the knee, and finally the dorsiflexion of the ankle joint. In this way, they usually use the synergy to flex the leg on the affected side and cannot selectively flex the, for example, the knee joint or the ankle joint. And these two joints are one of the major challenges of the patients and clinicians, because really difficult to obtain, to activate these muscle groups, hamstring muscle groups and dorsiflexors of the ankle. And they have no control over the knee extension. And sometimes it's really hyperactive, have severe spasticity that cause hyperextension of the knee joint or generic curvature. Therefore, we need to pay attention to assess the severity of the spasticity of the knee extensors. And if severe, we need to normalize it, not to paralyze it, to normalize it, using the techniques provided by Boban, or if not effective, using other techniques to normalize the spasticity of the knee extensor. All right, one of the challenges, as I said, is the lack of ankle dorsiflexion. And this lack of ankle dorsiflexion causes hyperextension of the knee because the pedestrian mid-stance, various stages of walking is disturbed due to the lack of ankle dorsiflexion. Because due to the lack of ankle dorsiflexion, they cannot perform, they cannot make weight transfer over the standing leg, and therefore it is difficult or impossible that will cause general curvature or knee hyperextension that must be treated if developed this general curvature or knee hyperextension. Due to the lack of knee flexion and ankle dorsiflexion, they used a compensatory strategy when walking. They raise the leg, use a circumduction, and then bring the foot over the ground to place it on the ground to walk. This type of walking, circumduction gait, raising the hip joint, raising the leg overall, and with a circumduction of the leg, they can bring the affected leg forward. Therefore, for this reason, due to the lack of knee flexion and ankle dorsiflexion, they use a circumduction type of gait that led to the stiffening of the lower extremity on the affected. In this way, they can control the collapse of the leg on the affected side through the stiffening of the affected leg. All right. What problem you see in these figures? First, in this figure, what do you see when compared with this one and this one?
There is a placidity in the left side. Placidity.
Left side is affected, that's right. What's the problem with this patient?
Position.
The position is not normal. As we said, the proper positioning is important from the initially flaccid stage to even recovery stage. Here you see the proper positioning are provided for this patient and for this patient. As you see, there's an upright position of the arm in the midline, and the affected arm supported over the pillow is placed on the pillow and is in front of the patient and can see the affected upper extremity. In this way, this trapeze is trying to integrate the both sides of the body and to prevent complications may occur after a while. Here is a bad position. The position of the front and the position of the affected arm. And this patient will develop some complications. Alright, and this one is also a good position, good posture. Proper position is provided for this patient. The affected arm is supported on a pillow with the affected arm in front of the patient. In this way, try to prevent the neglect and hemianesthesia to integrate the two sides of the body. Therefore, usually they are reluctant to shift the body towards the affected side due to the lack of balance and protective extension. We said they are reluctant to use the affected leg to shift the body weight over the affected one. Therefore, when standing up, even when standing up, when you ask the patient to stand up, they place the affected foot in front of the sound one. Why? Why, when standing up, the patients with hemiplegia possessor place the affected foot in front of the sound one? When standing up, assume the left side is affected. Even when standing up, they place the sound one in front of the sound, the affected one in front of the sound one, and they stand. Why they adopt this strategy when standing up? Why?
To compensate with the affected side. Compensate the lack of movement of the affected side.
No.
To get
Why?
more control. To get more control.
More control. More control. But why? That's right. It's for their control. But why they do that? Alright, but why they do that? What's the problem with their control that they adopt this strategy for standing up?
Because dorsiflexor, ankle dorsiflexor is
No,
active.
no.
So he will have
Don't have
equilibrium reaction.
due to the lack of balance reactions, protective extension on the affected side, they fear to shift the body weight towards the affected side. Therefore, they are dependent on for their functions on the sound side. When they place the affected leg in front of the sound leg, they shift the body weight towards the sound one to control their balance. In this way, all the body weight is shifted towards the sound one to control their balance.
Is that related?
Because they fear due to the lack of balance, due to the problem with sensations, due to the problem of spasticity. Therefore, they are reluctant to shift the body weight towards the affected one. In treatment, we do the reverse. We bring the affected one backward and place the sound one in front of the intact one. In this way, we shift the body weight when standing up towards the affected leg. All right?
Doctor, is the patient do this procedure and he know or voluntary?
What?
Is the patient do this procedure in voluntary way?
Yeah, they know that. They know that they are doing that voluntarily because they know that they don't have confidence to the strength of the affected leg. That's why when shifting the body weight towards the affected leg, they learn that step by step, gradually, that the affected leg can bear the weight of the body. Step by step, they will learn to shift the body weight towards the affected side. That's why, from the first, from the early period of the stroke, we try to shift the body weight towards the affected side. In this way, we will overcome their fear of falling. all right? But most of the time, even the patients have good recovery, even when standing up, they shift the body weight towards the sound side. And we must prevent this.
So what will happen?
For their recovery is important to shift the body weight towards the affected one. You have questions there? No?
What will happen if the patient during this procedure he have a problem in cerebellum? So he will have problem
No,
balance.
there is
and
no
body
problem
weight.
with cerebellum here.
I know, but I mean, where?
There's no
What's
problem
happening?
with cerebellum. Just due to the lack of protective extension, especially because they experience falling and they know that there is no extension of the affected one. They cannot support the body to protect the face from injury. That's why they shift the body towards the sound side. All right? All right, they have problem with balance, therefore it's difficult to stand on a small base of support. Therefore, using the small base of support in the treatment is one of the approaches we use. We use to promote the balance reaction, improving their balance in patients. As I said, they have circumduction gait due to the lack of, especially the knee flexion. They raise the affected leg. In this way, they circumduct the lower extremity and place the affected foot on the ground and walk with the circumduction type. You see here, what complication you see in this patient? Areza, what you see here?
Knee extension.
Is normal or not normal?
Hyper.
Hyperextension. As you see, there is a hyperextension. All right, that generate the weight of the affected region. And this must be treated. What brace can be prescribed for such a patient? One type of movement you need to prescribe for this patient with knee hyperextension and knee generator. And what type of brace you may prescribe for such a patient? What type of exercises first?
Stretching exercise.
What?
Stretching exercise.
Flexion,
Stretching.
Stretch.
She said stretching exercise.
reaching, stretching, stretching.
Yeah, for hamstring, like for quadriceps. Quadriceps.
What muscles must be stretched?
Hamstring. Knee flexors.
Yes, I know, I'm thinking about your answer. Why knee flexors? They are shortened with knee hyperextension or they are elongated.
Quadriceps.
Hamstring shortening occurs with knee flexion, not hyperextension. They are elongated, stretched already.
So we must
Okay,
stretch.
what type of exercise?
We must stretch quadriceps muscles.
Let me,
We must stretch quadriceps muscles and strengthening exercise for all muscles.
what type of exercise?
Strengthening.
Strengthening of what muscles?
Hamstring.
Hamstring muscles and
All the
That's
muscles
okay.
because
In
this
fact-
patient.
that's right. Flexion type exercises must be prescribed for such a patient. First, to activate the hamstrings, and if successful, you can step by step strengthen the flexion.
And grasping.
And now, your treatment is not effective. What brace, what type of brace can you prescribe for such a patient? with knee hyperextension.
This one, please rest. We need rest. Because we are tired. I need to pray. Need to get it out.
Alright, what type of brace can be prescribed for such a patient?
Massage the foot.
For a knee hyperextension,
BNF,
not PNM. You are doing exercises in the direction of flexion of the kneecap, but you want to promote the recovery. What type of brace you may prescribe for such a patient? Think about it, all right? Oh, you want to rest?
Yes.
All right. All right. Let's have a break for 50 minutes or
No. One. Until 1 p.m.
1 hour,
No, until 1 p.m.
1 p.m., 1
Yes.
hour.
Let's
Let's have half an hour break.
yeah.
No,
Do you agree?
we need to pray. We need to pray.
All right.
So, I mean, this session is finished and we will
Hi, 1 minute.
come back in the next session, which is started at 1 p.m.
أوقف؟
No,